They take it online.
How you doing?
So we're doing it. Okay, is it working now?
Yes.
All right, so for those of you who are watching via Integrity, I apologize if we got started. All you missed was me introducing myself and telling a few bad jokes and threatening them with burpees if they fall asleep. So we're pretty good to go here. So we're going to be talking about the healthcare delivery system, particularly how it's financed, because it's a very important concept to understand. So those are the, what if I have a laser on here? Should have done that. All right, I don't know if I have a laser. Anyway, those are the objectives we're going to cover. You've got the PowerPoint. You can read them. I'm not going to read it to you. But just rest assured that those are the ones that are in your syllabus. So there's a lot to cover today, so we're going to divide this up into two parts. Right? So we're going to spend the first little bit of class, or first half of class, talking about healthcare spending and cost in general. We're going to focus specifically on private insurance and private financing. Right? So that's a very important component of how healthcare is financed and delivered. Then we'll take a break at some point. We will come back and talk about how public insurance works, right? So Medicare, Medicaid, things like that. We're going to talk about how those are funded. There's actually some interesting stuff in there that I think is pretty relevant. And intertwined in there, we're going to talk about access to care in general, because when we talk about health insurance, that really kind of goes hand in hand. Make sense? All right. Has anybody not seen this before? You haven't seen this before? You haven't seen this before? Nobody's seen this before? Those of you who have me in undergraduate, I know you've seen this before, so I know at least some of you have. All right. Well, that's good, so we can talk about it. So what you have here is a objective ranking of healthcare delivery systems among industrialized countries. Right, so this is a study that's put out, it's called Mirror. I think it's put out. Who puts it out? Somebody from the World Health Organization and some other folks put this out. So effectively what they do is they look at different countries' healthcare systems and rank them based off of various measures and metrics and criteria and so on. Can y'all see that? I didn't move this. There's a good chance I'll hit my head if I move any further. So if you look at how they look at healthcare systems in general, they look at these metrics of quality of care, so how effective care is, how safe it is, how coordinated it is, how patient-centered it is. Then they look at overall access, right? So like how many people have cost-related problems accessing healthcare, how timely can you get services. They look at the efficiency of the system, how equitable it is, and then they look at healthy lives. So they put all these things together and they rank various countries' healthcare systems by these measures, right? So for example, you might look at mortality-related outcomes. You might look at healthcare spending. So these are metrics that are standard across countries. Now, you're comparing quality metrics across countries. Obviously, there's going to be some variability in there. Things might be defined differently and so on. But as a general mental exercise, it's helpful for us to see, roughly, where the U.S. healthcare system stacks up against healthcare systems from other countries. Right? So if you look over here, at the U.S. healthcare system, that number is 11. I need my laser. I know this one has a laser. All right. So do you think 11 is bad or good?
Terrible.
Huh?
Terrible.
Terrible. I wouldn't put it exactly that way, but yeah, because I'm a nice guy. Yeah, 11's not good. So if you just rank the U.S. against other healthcare systems, we rank pretty poorly compared to other industrialized countries. If you look at where we're getting weighed down relative to what we see in other places, cost-related problems in accessing care, right? We're going to talk about that in a minute. Efficiency, we'll talk about that in a minute. Equity, not everyone has the same access to healthcare-related services in the U.S. That's an issue. And here's the big one, healthy lives, right? That's a problem. So when you look at these metrics across countries, we get ranked dead last. Now, a couple things to point out here. You know, we're middle of the pack or so when it relates to quality of care and things like that. But there's this underlying notion that we spend a lot of money on healthcare but don't really get a lot in return is what's really dragging us down when you start comparing outcomes across other countries. So lest we get too down on ourselves, let's take a look at the United Kingdom, right? So where do they rank? Number one. Is that good or bad?
Good.
You're just ranking numbers, that's good, right? They're ranked first. So when it comes to quality, access, and so on, they're at the top. Look at their healthy lives. Where's that 10? Is that good or bad? That's not very good, right? So there's a important point here in that you can have what is objectively measured as a good healthcare system, but it still fails to produce the type of outcomes that you might expect. Why do you think that is? What are some reasons why you can have a great healthcare system, but your outcomes are still not where they need to be?
People don't utilize. People don't utilize.
Not utilize, but some other things that factor in there. Health behaviors, social determinants, like all those things that we talk about in public health, all those things are legitimate reasons why, even if you have a fantastic healthcare system, there's still lots of other issues that are at play there. So let's look at France, for example. So the French system ranks number 9, which is only like 2 behind the U.S. So by any objective measure, the French healthcare system is not particularly great either, yet in healthy lives they rank number 1. Okay, so just important to balance it out, right? So you're going to hear me beat up on the U.S. healthcare system at various junctures throughout the day. I guess beat up is not really the best word. It's like we're just looking at if you can't acknowledge where your issues are, it's very difficult to solve them, right? And unfortunately, there are a lot of issues that we need to address. But at the end of the day, healthcare is just one component of a bigger picture of what makes people healthy and well over the course of their lifetime. So we don't want to lose sight of that fact. However, it is a very important one, as we'll see in a few minutes. So when I get confused, I got 2 clickers in my hand. So, you guys seen something like this before?
Yes.
So this is healthcare spending per capita in the U.S., right? So we are up here, and the other industrialized countries that we compare to tend to be down here. So how do you interpret that? Are there any epidemiologists or future epidemiologists in the group? You hope? You're only in your first semester? Right, so how would you interpret this? This is per capita healthcare spending. What does per capita mean? Yeah, that's the average amount of healthcare dollars spent per person. Okay, so how do you interpret this? How much does the U.S. spend on average per capita on healthcare? Close to $9,000. Right? What's the next closest country spend per capita? 6,000. Right? If you drop past that one, we spend about double per capita as what any other country in the world spends on healthcare. So we spend twice as much money per person on healthcare-related goods and services than any other country that we get compared to. What do we know about life expectancy in the U.S. compared to other countries? I took this slide out, and I wish I didn't because now it doesn't make a lot of sense. What do we know about life expectancy in the U.S. compared to other countries? Is it higher or lower?
Lower.
Lower. How much lower? A little bit or a lot? Split the difference and say kind of a lot. Is that a word? Yeah, so we spend a lot more money on healthcare and healthcare goods and services, but by any objective outcome measure that we look at, with mortality being kind of like, the big one, like we just don't see a lot of value for the amount of money that we are spending on healthcare services. So if you look at it another way, the U.S., and this is a little bit older, this is from 2012, if you push this out to 2018, it's close to 20% now, so about 18% or so. If we spend about 18% of our GDP, which is the gross domestic product, which is a measure of economic output, we spend about 18% of our GDP on healthcare-related goods and services alone, right, compared to what you can see from all the other countries here. Now, if you flip back at this one, you can see that, healthcare spending is an issue that every country is dealing with, right? So the trend is going up for everyone, but it's going up at a much higher rate and proportionally larger in the U.S. than everywhere else. And it's the same thing for the percentage of your overall economy that goes to healthcare-related goods and services, right? So we spend a lot more money on this kind of thing than anyone else, but yet our life expectancy is significantly lower. It's not just life expectancy, it's the quality of life in the later years is equally as bad as life expectancy, right? So we spend a lot of those last years dealing with a lot of chronic conditions and, not necessarily living life to the fullest per se. So these are some things that we have to contend with. So the question obviously, is this inherently bad, right? Like if you're going to spend this much money on healthcare, is that really a bad thing, right? Like, is there a magic number that says this is the most money that you should spend on healthcare if you want to be efficient, right? You can make the argument that spending on healthcare would actually be a good thing, right? Like, if you can invest more money in healthcare and produce better health outcomes, then you can make the argument that why shouldn't you spend 20% of your overall economy on healthcare if you are extending the quality of life of your citizens, allow them to be productive members of the workforce and build the economy and things like that. The issue is we just don't see any kind of return on that investment, right? Like that's a logical argument to make, but the reality is we spend a lot more money and keep spending a lot more money. We have absolutely nothing to show for it, right? So that's kind of where we are now, and it's not just that, but a lot of people are worried about the trajectory of healthcare spending. So if you kind of push this back to the 1960s, 1965, what happened in 1965? See how smart you all are. What happened in 1965? Why would this thing start taking off like a rocket ship in 1965?
Is it Medicare, Medicaid?
Medicare, Medicaid, passed under Lyndon B. Johnson, right? So before that, you can see roughly where healthcare spending was right now. These things are adjusted, so these are current trends. So when Medicare and Medicaid went into effect, that put a lot more money into healthcare in general, and it's been increasing significantly ever since then, right? You can see that it's increasing across the board. So private insurance spending is through the roof. Medicare and Medicaid spending is through the roof, and more importantly, if you are a consumer of healthcare goods and services, this one should be of a concern for you. Out-of-pocket expenses are going up significantly as well. And those are things that we'll talk about over the course of the afternoon. So, again, it's not so much that we're spending a lot now, which is not great, but if you look at the trajectory of where spending is heading, do you think it's heading in a good direction or a bad direction? Okay, so 17 to 25 is not good. That means we're spending even more money on healthcare. We're projected to spend even more money on healthcare over the next few years. What's one big factor that may contribute to that estimate? Let me see how smart you all are and see what you know. And there are lots of factors, but like why would we see a pretty big jump coming up, like kind of starting now and over the next several years? Yes, the baby boomers. The baby boomers are starting to retire. They're all hitting Medicare age, right? Which means that they'll qualify for Medicare as an entitlement program, which we'll talk about in a little bit as well. Okay, who doesn't know what I mean by baby boomers?
I don't.
All right, all right. So I'm going to do my best not to make it crude and keep it somewhat dignified. So, like, there have been a couple world wars, right? Like, we don't like to talk about them, but there have been a couple world wars. After World War II, and things went well for the U.S., and when all the soldiers came home, they were happy. All of their significant others and their wives and girlfriends and spouses, like they were all happy. Everybody was happy. The war was over. The economy was booming because people were back to work. What happens when people get happy?
They have lots of babies.
They have babies. Right. So what happened after the war, like in the, I don't remember the exact date, but there were a lot of babies born, and these are called the baby boomers. And those baby boomers are all doing what now? They're hitting retirement age, which means that they're going. What? I missed that one. What was it? Yeah, so we'll talk about that when we talk about Medicare. It's we're going to have some problems with Medicare, but it's a short-term problem because once they all die, it'll stabilize them. Anyway, all right. So yeah, that's a big driver behind this, right? Like the baby boomers are retiring, so that's going to create some issues. Another issue that we have to contend with You guys heard this general thing like the 80-20 rule? I can't remember exactly what it's called. Like I've heard it in basically the context of everything, like ever. Like everybody's like, oh, 80% of the people do 20% of the work, or 80% or 20% of people do 80% of the work. You guys know what I mean, right? So interestingly enough, this applies to healthcare too. So this will blow your mind, right? So 1% of the population in the U.S. accounts for 21% of all healthcare spending. I want you to think about that for a minute. 1% of the total population accounts for 21% of all spending. The top 20% account for 80% of all healthcare spending. So the bottom 50% of the U.S. population accounts for about 2.7% of U.S. healthcare spending, right? What does this tell you? What should this tell you?
You're screwed if you're poor.
Not exactly.
There is an inequality.
Not exactly. I mean, those are all true, but not in the context of this slide. It means that there are a handful of really sick people out there that are costing a lot of money for various reasons, yeah.
So you don't mean like top 1%, like in the terms of top 1% of wealth. That's just like
No, 1% of users. Like
Okay.
1% of healthcare users account for 21% of all healthcare spending. Right, so it's kind of a measure of, yeah, I should have clarified that. I don't think the slide may not be labeled as clear as it should be. Yeah, so 1% of people who use healthcare services account for 21% of the total healthcare dollar. Right, so there are this group, 15, 20% of the population that tend to be very ill, tend to have a lot of chronic conditions. There are a lot of issues around end-of-life care that factor into this as well. But the point being, it's not like everybody is generating ridiculous amounts of healthcare spending, right? Like this tends to be a little bit isolated towards groups of people that may be disproportionately burdened with some diseases and things like that, which again is an issue that is an important one to consider. So, why are rising healthcare costs a problem? Why are they a problem for the government? Yeah, I'm cool with awkward silence, so you're not going to wait me out if I ask you a question.
I mean, the government has to pick up the tab with the taxes.
Yeah, so the government pays for a significant chunk of healthcare in the U.S. So if healthcare costs are rising in general, that means that they're going to have to pay more, which they're going to have to fund from somewhere, which will probably come out of your paychecks at some point, right? Why is it a problem for employers? Loss of work? Yeah. Why else is it important for employers?
They provide a lot of insurance too.
Yes, we're going to talk about that in like 2 slides. Employers are a major payer of health insurance for the majority of the population. So if healthcare costs go up, the cost to employers goes up as well, which can create some problems. Did you bring Amy Roots in here? You guys are killing me. Minis, donuts, gosh. All right. So, sorry, a little break there. Individuals. Why should you as an individual be concerned about rising healthcare costs?
If you can't afford it, then you can't live well.
Yeah, like you're going to have to pay for it too, right? Like your employers are going to pick up some, the government may pick up some, but guess who else is picking up some? Right, you are. We'll talk about what that looks like in a few minutes. So, we're not talking about rising healthcare costs just for the sake of talking about rising healthcare costs. We're talking about rising healthcare costs because there are real implications for the government, there are real implications for employers, and there are real implications for people, even beyond just the affordability issue, just the constant challenge of trying to maintain health insurance coverage when it's getting harder and harder and things are eroding and it's getting more and more difficult, right? Now, over the course of the next, 2 hours and, 2.5 hours, I want to give you some personal references that I'm dealing with right now around some of these things, right? Like I'm dealing with a lot of these things with my parents who are in that transition period, like into retirement, but not quite eligible for Medicare, and trying to figure out, because my mom had an accident and can't work, like how to keep her covered for this next year until she can hit. You're going to hear me talk about some of that stuff here in a minute, but the point being is like it's very difficult to navigate this stuff, right? Like it's very hard, and there are real implications, not just in terms of healthcare costs, but these things have implications on people's lives, like your ability to keep yourself healthy, your ability to stay out of bankruptcy because of medical bills and things like that. So, all right, that was all like preparatory framing stuff, which I expected to be a review. So let's talk about the actual finance. Who pays for what in the U.S. healthcare system? Like when we talk about that 20% of GDP that goes towards healthcare spending, where does it go? So if you look at where it goes, it's always interesting to follow the money. So about a third of all healthcare spending goes towards hospital care. People go to the hospital, people stay in the hospital, people die in the hospital. The hospital is still very much the centerpiece of the backbone of the U.S. healthcare system. So about a third of it goes to hospitals. About 16% goes to pay physicians and pay for physician services. About 10% or so go towards prescription drugs, which that doesn't sound like a lot, but that's one of the fastest growing sectors of this overall pie. Nursing care facilities, home health care, administration, reinvestment in the system. Here's an interesting one. Government public health activities. How many of you are going to have a public health degree when you get out of here? You'll be happy to know that only 2.5% of that overall healthcare spending goes to public health. Right? Shocker. So again, follow the money. You can see where a lot of this stuff goes. So when we talk about financing, like I'm using that term, when I say financing, all I'm talking about is the mechanisms that we use to pay for healthcare. Like that's what I mean by financing. So in the U.S. healthcare system, there are a couple different sources that we have to help pay for healthcare goods and services that are delivered to people. So we have private insurance, which can be private insurance through your employer. Right, so I work for East Tennessee State University, and we're technically state employees, so my insurance is through the state of Tennessee. Right, that's private insurance. Private insurance can also be whenever you don't have an employer that offers coverage, and you have to just go buy insurance on your own in the private market. Right, that's private market insurance. So about 7 to 10% of the population falls in that category, and that's one that is really difficult to manage, particularly when we talk about the Affordable Care Act. A lot of the reforms we're trying to help stabilize that particular market. We'll talk about that in a few minutes as well. So that kind of all falls under the private insurance, so employer-sponsored and private insurance market coverage. We also have public sources, which are Medicare and Medicaid. You got some VA and some other ones in there, but for the most part, Medicare and Medicaid are the big ones. So those are public insurance sources. What do I mean by public insurance sources? Yeah, I'm hearing government. I can't hear the mumbling in between, but I don't know if that's like you're just saying government mumbling something or just, anyway. So those come from government sources, right? So those are generally collected through some type of tax revenue, whether it be the state, federal government, or whatever. So those are redistributive programs where you take money from the government and redistribute it to those who are eligible. Well, and then like another source of spending, which you don't really necessarily think about as spending, is uncompensated care, right? So when you have healthcare facilities and people don't have insurance and they have to provide the services anyway, those uncompensated care costs are also considered a source of financing, right? They're not getting paid for it, but it accounts for a certain amount of money in the system. So if you printed these slides off earlier in the day, I apologize because they're going to be out of order. Usually I say this for the end, but I don't know. I'm feeling a little bit froggy today and mixing it up. So I'm going to cut to the chase here and tell you why insurance is so important, right? So why we're spending so much time talking about health insurance. So if you look back at the proportion of the U.S. population that didn't have health insurance over time, you can see that, roughly on average, over the decades, it really kind of hovered between 16 and 18%, right? So about 46 or so million people across the U.S., 15 to 20% of the U.S. population at various times do not have health insurance. So if you don't have health insurance, right, if you're 20 years old, maybe it's not a big deal. If you're 50 years old, it's a big deal. But at any point in time, roughly that proportion of the population did not have health insurance. And it's a little bit, because this is zeroed and it's a lot of years, if you look at the years leading up to 2010, right? So what happened in 2010? Y'all better know this, or I'll make you do burpees. What? Not really. I'm just teasing you. What's up? Yeah, the Affordable Care Act in 2010. So you can see that in the decades leading up to the Affordable Care Act, the proportion of those that didn't have insurance was starting to go up, and it was going up fairly consistently in the decade leading up to it. When you look at what happened after the Affordable Care Act, what happened to the insurance rate? It went from 18.2% down to what? It's about 10%, give or take, depending on which estimates you look at. So it almost cut the rate of uninsurance in half, right? So let's talk about why this even matters in the first place, right? Too many clickers. So first of all, if you look at who doesn't have insurance across the country, it's not uniformly distributed by geography. So if you look in the southern states, North Carolina, South Carolina, Georgia, Alabama, Florida, you can see that they had higher proportions of their population that didn't have health insurance. If you look across the South and the border states, the rural states, like a lot of those states had uninsured populations that were 16% or above. But this is, or back up, this is in 2013. Before 2013, it looked even worse than this, right? So this was in the early stages of the ACA. Okay, these other southern states, Kentucky, Tennessee, West Virginia, Virginia, Ohio, Indiana, those looked a lot worse. But what happened with the ACA that may have helped mitigate that a little bit? Right, Medicaid expansion. Right, so in a lot of these southern states that historically have had high rates of uninsurance, like the Medicaid expansion really kind of helped with that. So I'm kind of jumping the gun here. But the point was not to talk about the ACA, we'll talk about that next week. The point was to illustrate that although the overall population roughly was about 18% that didn't have insurance, that was not uniformly distributed, right? So Kentucky, for example, I think at one point in Kentucky, over 20% of their population was uninsured, like 23%, something like that. So, there's just a lot of variability, and not surprisingly, a lot of your, a lot of states in the Northeast tend to have better coverage and things like that. So, another thing I want to point out about insurance. So some of you are probably thinking, well, that 18%, that probably includes a lot of young people that didn't have insurance coverage, which is true to some degree. A lot of people will make the argument that it also includes a lot of people who have money and just pay for their health care services because they're able to, so they just don't carry insurance. And there's a little bit of that in there. But one thing that I think is important to point out when we talk about who doesn't have insurance before the ACA and who doesn't have insurance after the ACA, only about 10% of those people are people that are not poor. By not poor, meaning that they probably are like just wealthy enough to where they don't have to buy insurance. 90% of everyone who doesn't have insurance falls in the poor or near poor category. Right? So these are people that are under the federal poverty level, like at varying degrees. So I don't think that we should lose sight of the fact that the people who don't have insurance are people that are on the margins, right? So these are the working poor. These are people who make too much money to qualify for Medicaid, but they don't make enough money to actually buy insurance in the private market because it's so ridiculously expensive, or it was part of the ACA. So these are what we would call the working poor. So let me ask you this. of the proportion of the U.S. that does not have health insurance, what percentage do you think are either working full-time or part-time or have a direct connection to the workforce? So of the chunk of people who don't have insurance, right? So let's just talk about some of our ideas about who these people are. Are these people that are sitting around not working? Are these people who are sitting around twiddling their thumbs, watching Dr. Phil in the afternoon? Maybe a few, but the vast majority of them, I want to know what percent of that group that doesn't have insurance, what percent do you think are actually connected to the workforce?
90.
90? Higher or lower?
Right.
Higher? I kind of set y'all up a little bit. It's about 75%. So about 3 out of 4 people that are in this category are actually connected to the workforce, right? So whenever we say these are the working poor, like the people who don't have insurance, the people who are like destitute and materially poor, they have access to insurance sources. We're talking about people that are on the in-betweens that affordability is a problem, right? So just keep that in mind as we talk about insurance and we start talking through some of these things. So if you don't think that it matters, I'm going to tell you why it matters. So when you look at Medicaid, employer-sponsored health insurance, and the uninsured, right? So this is looking at 3 groups of people that have insurance. Stupid thing. This is usual source of care, right? So almost 97 to 100% of people who have even Medicaid, right? So there's also this idea that people who are on Medicaid may not receive the same level of care as people that have insurance, and that's simply not the case, right? So Medicare and Medicaid, so people who are covered by private or public sources, almost all of them have a usual source of care. Now that's not really a great research question, but it is what it is. Compared to 75% of people who don't have insurance, and these are kids, right? So we're talking about kids here. Well child visits. Now, 85% of covered kids have well child visits, right? Like these are things where you get your immunizations, your well child checkups, and things like that. About half of kids that don't have insurance fit that category. Specialist visit. They have about half the rate of visit to specialists that kids that have insurance do. If you look over here at non-elderly adults, right? So these are people that are not covered by Medicare, like just people my age. I'm not going to tell you how old I am, but usual source of care, about half of what it is for people that have insurance. General doctor visits, it's less than half. Specialist visits, even worse, right? So for adults, people who don't have insurance, you just don't have the same level of engagement with things like general doctor visits, right? Like these are preventive clinical services, things that you need to keep yourself healthy over time, right? It gets worse. So this is the likelihood of various outcomes, like health services or mortality-related outcomes, comparing those who have insurance and those who don't, right? So what you need to know is this line running through here is what it would be if it was equal to private insurance, right? So it's called a counterfactual. Hopefully you'll learn about that in EPI at some point. What you need to know is that for these, being below that line is bad. And for this one over here, being above that line is like really bad. So when you look at people who don't have insurance, they're much less likely to get the same level of preventive health care services, particularly around things related to heart disease, things like cardiac caths, various procedures that help keep you alive. They're much less likely to receive those procedures because they don't have insurance. They're much more likely, 30% more likely, to have a hospital-related death than people who do have insurance, right? So there's a picture emerging of people who don't have insurance are much less likely to have access to the things that can keep them out of the hospital. And when they do show up in the hospital, the wheels have already fallen off the wagon and they're more likely to die, right? So again, insurance is important. All right, it gets even worse. Diagnosis of late-stage cancer, uninsured versus privately insured. So colorectal cancer, lung cancer, skin cancer, breast cancer. They're twice as likely to be diagnosed with cancer in later stages than people that have health insurance. Why is that? That's not a trick question.
like screening and.
Yeah, they don't have access or they typically do not receive and or have access to the type of preventive clinical services that catch this stuff early, right? I go to the doctor once a year. He does a bunch of lab work on me and checks things out. Like, that kind of stuff doesn't happen if you don't have insurance, and this builds up year after year after year. And then over time, they're just much less likely to be diagnosed with later stages of cancer than people who have insurance, right? And this is just looking at everyone. If you looked at this by income, if you look at this by racial and ethnic disparities, like, these numbers would be even worse, right? This is just kind of an average. So, again, I'm trying to paint this picture for you as to why health insurance is so important, right? Because I think that you kind of get flippant about, whatever, health insurance. But this stuff is, like, seriously critically important for some people, and it's actually a matter of life and death. So here's my final, so what about why we are focusing on health insurance so much in this class, but, in general within the health services research world. So there was a study that came out in 2012. So you all know that the ACA was passed in 2010. Right? What was the ACA modeled after? Does anybody know?
Bill Clinton's.
Massachusetts.
Yeah. And listen, I grew up in Eastern Kentucky, so I don't like to say Massachusetts because I typically get it wrong. But the ACA was modeled in large part after a state-level reform that happened in Massachusetts. So you're from Kentucky, I apologize. I grew up there, so I can say that. All right. So the ACA was modeled after what happened in that particular state. So in Massachusetts, probably still said it wrong, that reform happened in 2006. Right? So there was a study that came out in 2012. Right, this is called a natural experiment because you have all this data on health outcomes prior to this big overhaul of their system, and then you have all this data afterwards. Once it was in full effect, you could actually see what happened over time. And some researchers from that area looked at mortality rates in that state before the reform and after the reform. Okay, so you're just going to have to trust me on this. Like, I do research for a living. Like, that's my primary gig here. The study is as good as you can get without doing a randomized trial. So they matched counties and boroughs in Massachusetts with comparable counties and boroughs outside the state. Right? So this was a propensity-matched cohort where they were looking at what happened in that state compared to what would have expected to have happened had the intervention not occurred. Matched the counties as best they could, no statistical difference between them at baseline, and looked at changes in mortality patterns before and after. So what they found was that there was a 3% reduction in mortality in that state after the reform compared to what would have been expected had it not occurred. Okay, so how many of y'all think a 3% reduction sounds like a lot? It's all right. It doesn't. Like, it's not very impressive unless you do the math, right? So, and I'll just say this. Mortality is one of those measures that's really hard to move, right? Like, because everybody dies, so it's not like a rare thing. And it's really hard to shift the distribution of something like mortality. Very, very hard. So the fact that they even moved it at all, and it was statistically significant, is impressive. So if you do the back of the envelope calculations, so the ACA covered about 16.9 million people net gained coverage from the ACA. So if you take that mortality rate, so for every 830 individuals who gained health insurance that didn't have it before, you prevent one death. Right, so it's kind of a numbers needed to treat metric. So if you do a back of the envelope calculation, in theory, had the ACA been implemented the way that it was supposed to, I mean, that's a theoretical 20,000 deaths that were prevented by that many people getting access to health insurance if you extrapolate what happened in that study to the national level. Right, now, again, I'm a researcher, so I tell you that's a bad idea. Like, you don't want to do that. But just for the sake of thinking about, at least at the state level, there was a significant impact. And theoretically, you could expect to see at least some of that happen at the national level. So the point being is that insurance matters, right? Like, and it matters not just in terms of like keeping you out of bankruptcy court. It matters in the sense that it is the key thing that gets you access to goods and services that can keep you healthy and keep you alive, right? Now, we'll talk about the very end of class. It's not it doesn't always equate, insurance doesn't always equate to access. Why is that? For those of you who grew up in places like me, you should know the answer to this very quickly.
Hospitals aren't always adequately prepared for things in need.
Hospitals are not always adequately prepared. How many of y'all grew up in a place where there was no hospital? How many of y'all grew up in a place where there was a hospital, but you didn't want to go there? Right? How many of y'all grew up in a town that had one doctor for the entire town? Right? So some of y'all grew up in places like I did. Right? So even if you have insurance, there are places where you don't have access to providers because they're underserved areas. There aren't enough providers to see everyone that's there. So again, insurance is really important. It's not a panacea, particularly if you live in a vulnerable community. However, it is very important. Right, I was spending a lot of time talking about health insurance. That was all still kind of framing stuff. We're just not getting to the financing stuff. You guys still with me? It's 1:46. All you ones that are eating Annie Roos and Mimi's, are you like crashing? All right, so here's the key. Insurance is important. When we talk about financing, a lot of the financing in the U.S. healthcare system centers around providing access to insurance for the population. That's the key. So the U.S., the financing of healthcare in the U.S. is complex and it's unique. Right? How many healthcare systems across the world are private market-based systems, that they rely on a market to deliver health insurance to their populations? How many countries in the world fit that criteria? One. You want to guess who it is?
It's us.
The U.S. Now, that's a little bit of an asterisk. I think there's like some small country somewhere that like has a market-based system, but of industrialized countries, the U.S. is the only one that uses this private, employer-based, market-based scheme of providing insurance to their population. Most of the other countries in the world have a central, I mean, they vary, they look very different, but they're ultimately financed by the government or provided by the government, even if it's delivered in the private sector and things like that. Now, there are reasons for this, and because I've already spent a lot of time framing things up, I'm not going to go into. But it has a lot to do with, we talked about baby boomers earlier and like wars and things like that. Part of the reason the U.S. has this type of system is because after World War II, the infrastructure was devastated in all the other European countries. Right, so to rebuild their infrastructure, to rebuild their population, the governments had to assume control of those rebuilding tasks, which included providing health care for people. The U.S. was the opposite, in that at that time, the economy was booming, employers were able to provide health insurance to their employees, and growth was happening, so there was just like, let's just keep it rolling. Let's just keep it like it is. We'll be able to cover everybody because there's no end in sight for how much the economy's growing. Eventually, everybody will have a job, and we can leave it the way it is. And that's exactly what happened. And that's why it's still the way that it is today. The problem is that what's happened with employment over time. Yeah, it's gotten a little bit dodgy. So when your whole system is geared around employer-sponsored coverage and you have issues around employment, that can be problematic. Although unemployment is at its lowest rate like ever right now, I think. So it's complex. We have many payers. Right? How many insurance companies are operating right now in the U.S.? You guys know how many insurance companies pay bills in the U.S. right now?
A lot.
Yeah, there are a lot. Hundreds, thousands. It's a little bit of a trick question because the top 5 insurers control about, should be full numbers, I can't remember the exact number. The top 5 insurers control over half of the insurance market. I think it's more like 70% of the market. So it's a little bit of a trick question. But the point is, you got the government, you got private insurance, you got employers, you got a lot of people that are involved in paying the bills. Many different types of plans to choose from. If you ever had to sign up for health insurance when you get a job, you're like, oh my God, which one am I supposed to choose here? I have no idea. At least this is what happened to me when I was younger. Many programs, many payment methods, right? Like every insurance company has their own billing, they have different ways of doing things, like all that stuff is a factor here. So if you look at it, right now about half of all people in the U.S. are covered by their employer. So about half of us have insurance through our employer. About 20% are covered by Medicaid. About 14% are covered by Medicare, which that number is going to get bigger. You know, right now about 10% or so are uninsured. You got about 7% that are kind of in this private insurance market category, right? It's called non-group, right? So, by far, the largest burden for providing health insurance for the population falls on what we would consider private entities. Businesses, people who provide insurance for their employees. So they're responsible for having all their insured. Now, public sources account for about 43% of that. So although we are considered a private-based healthcare system, you still have a big chunk of that that is covered by the government, right? So that's where we get a lot of this conflict between, you know, private market versus government. You know, the government, because they pay for so much, they still have a lot of say-so in what happens, particularly as it relates to Medicare and Medicaid. What we've seen is that, you know, since 1965, there's been much more of a shift towards public sources of insurance, right? So as these programs expand, as, you know, private companies stop offering plans, things shift around. We've seen a gradual shift over time to where more people are covered by public sources, and as that happens, it gets less and less private, more and more public, and you get a lot more friction between the two. So health insurance. So health insurance is good, right? But because we have, let me back up and ask you this. We have a market-based healthcare system. Is health conducive for being considered a market?
No.
Right, what do I mean by market? Talking about traditional economics here, right? I mean, you all have an econ class. What do I mean by market?
You can like shop around and like look for the best price.
Yeah, so you have many buyers, many sellers, right? And I, as a consumer, can shop around and look for my best value, right? So if I'm going to buy a flat screen TV, I was in Target the other day and I was like, we knew there were so many flat screen TVs, right? But I've got like 50 of them right in front of me that I can choose from. Look at the picture, look at the cost, look at the features, right? So that's something that you can do that. So there's many buyers, many sellers. I'm an informed consumer that can make a decision, right? So if you price yourself high in an open market, what happens?
Demand increase.
Yeah, it's a supply and demand issue, right? Like you kind of agree on this negotiated price. If you come in the market too high, you'll get driven out of the market. If you come in too low, you won't survive. The market equalizes and the world goes on. How conducive is that for healthcare? Can you have many providers moving in and out of the system? The answer is no, because right, you have to go to medical school, you have to be licensed, you have to be all these things to touch people in the healthcare system, right? So you can't just move in and out of the market. You can't just go open a facility and start treating people without going through all these hoops. And what about health itself? Is it a commodity? Is health like broccoli or flat screen TVs? How predictable is health? It's not, right? You don't know what's going to happen when you walk out of here in a few minutes. You may fall down the stairs, may get hit by a car, you may be fine. But it's unpredictable, right? So that unpredictability It's different than flat screen TVs, right? So the point being is that insurance is good because it protects us from loss financially. But insurance creates some issues because we already have a really iffy market-based concept at best, right? Like health and healthcare, really, in my mind, and you can argue this, it's not really a market, right? It shouldn't be delivered in a market because health is different than flat screen TVs. But insurance complicates it even further because now, as an individual, we got this third party in the mix. So it's not just me and the provider agreeing on a price and agreeing on a service. We have this other person in here, whether it's the insurance company, the payer, or the government. It's also in the mix now. They're negotiating with me on premiums. They're negotiating with the providers on price. So now you've got this third party mixed into what should be a buyer-seller interaction. Right, and it gets even more dicey because let me ask you this. What do you do with health insurance when you have it? Not a trick question. You use it, right? If you're sick and you have health insurance, what do? You go to the doctor, right? Do you pay the full cost of that doctor visit? No. You might pay $5, you might pay 20% of the bill, but you very rarely, unless you don't have insurance, pay the whole bill. If you didn't have health insurance and you got sick, what would you do? You'd probably wait to see if you're going to die. And if you didn't get better after a couple of days, you might go to the free clinic or something like that. But you're not going to be as quick to go see the doctor. So the point being is that when you have insurance, what do you do with it? You use it. Do you use it in the same way that you would use it if you had to pay the full cost of that visit? No. You use it more or less. More because why? Because you don't have to pay for it, right? I may be able to raid my kid's piggy bank and come up with a $5 copay to go to the doctor, right? But if you don't have insurance, you're going to think about that a little bit differently. So that concept, right? This is a demand side issue. So that concept is called moral hazard. So the reason that it complicates the market interaction and the reason that it contributes to healthcare spending is because when you're shielded from the true cost of what it takes to provide that good or service, you're much more likely to use it in a way that you wouldn't if you had to pay for it yourself, and that use is more use, not less use. So you're more likely to generate more cost or more spending because you have health insurance and you want to use it, right? When you're paying the premiums, why the heck would you not use it, right? So that's an issue that we have to get in with around health insurance. All right, there's another issue that doesn't get talked about quite as much. Are we as consumers the only ones who are guilty of this?
No.
What about your doctors? Okay, listen, let me say this before I get going. By no means, in no way, shape, form, or fashion am I trying to say that healthcare providers are dishonest people. Right? Healthcare providers, God bless them, like they have a calling, most of them. They're trying to do the right thing. They just want to take care of people. They're well-intentioned, altruistic people who just want to do right. However, some of you may end up in this position as business managers. Right? There are financial realities to operating a healthcare facility. If you don't make more money than you spend, what do you have to do to your clinic? You have to close it because you can't pay the bills. So there are some realities that have to be contended with here. So providers, do you think that they may treat you differently in the sense that they may be more willing to write for more labs or do more tests or do some other things because you have health insurance that they may not have done had you not had health insurance? And sometimes it's not just because they want to make more money. It could just be because they know you don't have health insurance, and it's like, well, this might be a luxury, but you're probably okay. There might be some of that going on there. But providers do the same thing, right? So when new technology comes out and you get higher reimbursement for doing a procedure that just came out compared to the one that you've been doing for 15 years, which one do you want to do? The one that lets you get more money, right? That's just common sense. People act in a profit maximizing behavior. Providers are desensitized from the true cost of providing those services, right? So like when I go to the doctor and I have insurance, they probably don't worry as much about, I'm providing these, like I want to check this, and this. Like it'll all be covered under your insurance, no big deal. Maybe I need it, maybe I don't. But they also get desensitized from the true costs of what that interaction should be. So there's a tendency to maybe do a lot of things that are perhaps unnecessary or could be considered unnecessary. Sometimes it's because you have health insurance. Sometimes it may be because of fear of litigation, right? If they think that you have the flu and it turns out you have cancer and then you go back and sue them because they didn't order a test that would have told them something like that, that kind of stuff really happens. And that's called defensive medicine, like that's a term that you'll hear used around that. The point being is that we can generate a lot of demand or a lot of service utilization because we're shielded from that cost. But providers can also generate a lot of additional spending because they're shielded from the cost. Sometimes it's because of that. Sometimes it could be because they're trying to manipulate the system and maximize their reimbursement, which makes sense. But we have these demand side constraints and these supply side constraints around health insurance that really complicate this market interaction. Right? It just makes it very difficult to really consider a true market. Now, to combat some of this stuff, health insurance companies want you to have some skin in the game. By skin in the game, I mean co-payments, co-insurance, and deductibles. That out-of-pocket that I showed you earlier, that's what this is. So co-payments are what? You can read it. You got it in front of you. I know you're reading it. It's fine. What is a co-payment?
cost patients pay at time of services.
Yeah, the cost you pay at the time of services, right? So, for example, after getting like 25 texts from my pharmacy telling me that my prescription was ready, I finally went and picked it up this week. And like I had to give them like a $5 copay for my meds. I have high cholesterol, go figure. My mom gave me a bad gene, I hate it for it. All right. So that's a co-payment. Co-insurance. What is co-insurance?
Co-payment,
Pay a percent of the visit, right? So you go to the doctor and you already met your deductible. The insurance pays 80%, you pay 20%. So if the total bill was $200 for your doctor visit, what's 20% of $200? $40. That's co-insurance. So a lot of insurance plans are structured this way. Deductibles. What's a deductible? Deductible is what I never burn through every year. So having insurance is useless right now. It's the first dollar you pay for every. It's the first dollar that you pay before your insurance starts to pay. You guys know what a deductible is?
yes.
All right. I don't want to insult your intelligence, right? But you have them with like car insurance, you have them with health insurance, right? So I think my deductible with my family coverage, the way it is now, I want to say it's like $5,000. So it's like $2,500 for me and then $2,500 cumulative for my family. So I have to pay $2,500 out of my pocket before insurance will pay anything. How many times in the past 5 years do you think that I've gone through my deductible in a year? 0. Right?
But there could be that one time.
Exactly. I have 3 kids. Right? Kids are crazy. How many of y'all have kids? How many of y'all have kids? Kids are crazy, right? Like they do crazy stuff. And I'll tell you all this funny story. So whenever I moved here about 4 years ago from the University of South Carolina. I see your Carolina sweatshirt over there.
What's that?
So I moved here from South Carolina 4 years ago. I said, I see your Carolina shirt. So when I moved, like there was this weird thing where my insurance cut off on July 31st at the University of South Carolina. But when I started here, like there was no break in my work. Like I started on Friday ended on Friday and started on Monday. But the state of Tennessee has a 30-day lapse. Like you can't be covered by health insurance until you've already worked for 30 days. So I had a 30-day gap where I fell into that uninsured category. Right now, I could have like bought Cobra. I could have paid for Cobra for a month to extend my coverage, but I would have had to pay the full cost under Cobra, not the part that I was paying before. I'm going to show you some sticker shock stuff here in a little bit. But for me to have paid the full price of that month to cover my family, it would have been, I want to say like $1,800, something like that, just for a month. Like that's the true cost of my health insurance per month. So it's like, you know, if I just put helmets on them, then I think we can roll the dice and make it 30 days. So sure enough, my oldest one, for whatever reason, decided that she wanted to put this little princess tiara, like little gem that she had, in her mouth. And what did she do?
Swallow it.
She swallowed it.
Yikes.
I was so mad. I was like, as soon as she told me, like, I'm on Google, like, you know, what's it like? Yeah, you can imagine what I was Googling, right? Like, what's going to happen here? Like, is it going to create a blockage? You're going to have to, like, do surgery and cut the thing out? Like, what's going to happen here? Luckily, she never developed a blockage, and I just assumed that it got past the way the dogs pass quarters and things like that. But anyway, I was so mad because it's like, oh, like, why? First of all, why do you stick that in your mouth? Second of all, why do you swallow it? Third of all, why did you have to pick 1 month and we didn't have insurance to do it? Anyway, it was fine. We were covered. But like, anyway, that's just kind of stuff we have to deal with. All right. So I'm going to run through this quick and then we're going to play a game. So insurance can take different forms, right? Now, we've kind of talked about this. But group insurance is basically employer-sponsored health insurance, right? So if you're an employer and you want to provide insurance for your people, like that's group coverage. So you go buy, negotiate with the provider, and they provide coverage for your people, right? So the state of Tennessee, that's a group plan. My mom's plan in West Virginia, where she worked for a small independent pharmacy that had like 20 chains, like that was a small group plan, right? Individual private insurance is where you have to buy insurance by yourself, nobody else to help you out in the private market. We're going to talk about how crazy that is in a minute. You can self-insure, right? So a lot of big companies will take money and self-insure themselves and put it away in a pot and then contract it out with somebody like Blue Cross just to actually pay the bills, right? So that's self-insurance. Now, managed care, like basically every insurance plan that you would ever enroll in now is some form of managed care where you have contracted networks that you have to stay in and the providers agree to take, the providers agree to see you at a discounted rate and things like that. But the one that's catching some traction now are these high deductible health plans, right, that have lower premiums. And I'll show you why these are attractive a little bit later. They're lower premiums, but they're high deductible plans. Right. Now, in the spirit of full disclosure, I just switched to one of these during open enrollment this year. Why did I switch to one of these? I already told you why. Because I've yet to burn through my deductible in all the years I've had insurance. Like even with kids and doctor visits and whatever. So for me, I've got enough money put away, put in a health savings account, take the lower premium. If you have money and you know how to navigate the system and you know how to use it, these things can be attractive. However, are they a solution for providing insurance for the rest of the country?
No.
No, they're absolutely not. So I feel a little bit hypocritical by saying that, but I'm acting in my own self-interest just like everybody else. All right. So here's what we're going to do. I want you to count off by fours. 1, 2,
3, 4, 1, 2, 3, 4,
1,
2,
3.
4, 1, 2, 3, 4, 5.
Don't mess me up. Wait. 3.
4, 1,
1, 2, 3,
1,
All right, remember your number. So if you're a 1, you are a 1, this is you. We're going to pretend here. I promise there's a point to this game. If you're person number 1, you are a 27-year-old you're a 27-year-old individual with a college degree. You're relatively healthy, other than just a few, like, a stuffy nose here and there or something like that. You're relatively healthy, no major issues. You have recently gone to work for a small nonprofit because that's what you millennials do. And that's great, but your small nonprofit does not offer health insurance, so you're going to have to go buy insurance in the private market. So if you were number 1, this is you, the idealistic millennial with no health insurance. Right, so I want you to think about what type of insurance plan might fit you if you're that person. Okay, person 2, you're 32, which sounds old to you but sounds young to me. You're married, no kids, no significant medical issues, but you are 32, and you work for a small company, small manufacturing company that doesn't offer health insurance directly. So if you're number 2, this is your life story, right? You're early middle-aged, working class with no insurance. Person 3, which is closer to me, sort of, you're 45. How many of y'all think I'm 45? Luckily, I'm not responsible for your grades, so you can answer. How many of y'all think I'm 45?
Lower.
All right, you passed. So you're 45, you're married, you have 3 kids. I've already said I have 3 kids, right? So when you hit 40s, things start to fall apart a little bit, right? You have borderline diabetes. You've gone to the doctor. You know that you have some issues you're going to have to contend with. You have borderline diabetes, and you're on hypertensive medications, like for high blood pressure. Again, you kind of the same way. Like you work for a small company, but that small company just doesn't have the resources to provide health insurance to their employees. So that's you. Middle age, married, kids, starting to have some complications that may cause you some issues down the road. So if you were number 3, that's your life story. Number 4, you're almost 60, you're married, you and your spouse both have chronic conditions that you're having to manage, right? Whether it's diabetes, hypertension, autoimmune disease, something like that. You were in pretty good shape before, but your company relocated, and because you're 60, you don't really feel like moving again. So you decide that you're going to stay put in your hometown, and you've got a new job because you've got some pretty good retirement maybe, but you don't have insurance. So you need to buy something that's going to get you from 60 to 65 when you can qualify for Medicare and say, I'm done. All right, that's your life story. So if you're number 4, that's who you are. Make sense? Okay, y'all see what we're doing here. If you're number 1, that's your story. If you're number 2, that's your story. If you're number 3 and 4. So here are your options. You're all going to go buy insurance in the private market because now you have access to it through your job. So plan A, roll the dice. I'm good. I'll take my chances. I'll be all right. Whatever. Plan B. Your premium is $150 a month, which is not too bad, but you have a $5,000 deductible, and you have the option of using a health savings account to help pay your medical bills. So health savings account, they take a little bit of money out of your paycheck that's not taxed, put it in this account that you can use to pay for your medical bills. So like it saves you money, right? So that's plan B. Plan C is that I got a $600 a month premium, a $4,000 deductible, and my co-pays are $15 and $25 per visit. So my premiums are higher, but my co-pays are pretty reasonable, $15 and $25. But I still have this ridiculous deductible, right? $4,000. It's a lot of money. Maybe y'all think $4,000 is a lot of money. It is, yeah. So Plan D, your premium is $900 a month. Your deductible is lower, it's $2,500 a month. And your co-pays are lower, $5 to $15 a month, right? So here, a little bit lower premium, more out of pocket. Here, higher premium, a little bit less out of pocket. Roll the dice. Here's your kind of classic consumer-driven health plan. Low premium, high deductible health savings account, right? So what I want you to do is take a minute and think about, based off of who you are, based on the previous scenario, whether you 1, 2, 3, or 4, which one of those plans would you pick? You need to be prepared to tell me why. So we've got we're not playing tic-tac-toe. All right, where are my ones?
What are y'all laughing at?
I didn't say anything funny.
Only one to raise your hand.
All right, where are all the ones? All right, so these are idealistic millennials. Okay, which plan did you pick? Okay, let me do this. How many of you all pick Plan A? How many of y'all are willing to roll the dice? 1, 2, 3, 4. Raise your hands. 1, 2, 3, 4, 5. It doesn't matter. It's not like a real life decision. It's a game. So of our ones, 5 of you are willing to roll the dice. All right. How many of y'all pick Plan B? 1, 2, 3, 4. How many of y'all pick C? How many of y'all pick D? One semester I actually had a number 1 that picked D. I'm, what's up with that? All right. All right. Where are my 2s? 2s, raise your hand. All right. How many of y'all pick Plan A? How many of y'all want to roll the dice? How many of y'all pick Plan B? 1, 2, 3, 4, 5, 6, 7, 8. Anybody pick C or D? Any of my 2s pick C or D? All right, where are my 3s? Raise your hands. All right, how many of y'all picked A? B? C. How many of y'all pick C? That's it. How many of y'all pick D? 1, 2, 3, 4, 5, 6. All right, close enough. All right, where are my 4s? Okay, how many of y'all picked A? There's actually some logic to that, right? Because you can just say, screw it, somebody else will pay for it, right? Like, I'll just not pay, right? Okay, let me back up. How many of y'all said wrong? How many of my 4s picked A? None? How many of y'all picked B? 1? How many of y'all picked C? Just 1 picked C? How many of y'all picked D? All right. So we're not going to hear from everybody, but of my 1s, Y'all are split between A and B. What was your rationale for picking roll the dice? Y'all better hurry up, man. It's gonna be. I'll keep you late.
I mean, even like the plan B was like 150 a month or whatever for the premium is still a lot, and then the health savings account option just doesn't seem like really that easy or really that logical. So it's just better to kind of play it out and see how it goes and wait till you make it.
Yeah. You don't have the equity necessary to put in the health savings account. It's not really relatable yet. $150. Think I can buy a lot of beer with that money. Anyway, all right. So y'all have picked B. What was your rationale?
But see, like in saying that, like you wouldn't want to pay that like 150, or like you think that's not, like you think that's still too much, or that like you don't want the health savings or like plan. To me, like as a young person, our healthcare costs, like if something were to happen to us, are sometimes so much larger because it's usually like a major accident or something. So it's like if you don't have anything, then you're going to be stuck paying a lot more than what you'd rather if you just like had some insurance.
So there's a little bit of risk aversion there, right? Like I could probably come up with 150 because if I get hit by a car or something bad happens, like I don't want to be totally bankrupt. Like they'll at least pay a certain amount, right? So I mean, those are, there's no right and wrong answer, right? Like your logic is your logic. That's what we're trying to get at. So my twos. Where are the twos? So all of y'all pick B. Where are the twos? So married, no kids, no significant medical issues, no insurance, right? You went with the consumer directed plan. What was your logic? What's your rationale?
I guess when I'm 32 and married and no kids, like I want to be thriving. Like I'm banking on like that being prime time. So I hope that I have a good enough job where I could pay, the 150 premium a month and be able to save money so that if something did happen between me and my spouse, we could pay for it. That's kind of where I'm thinking. Because things could happen.
That's sound logic. That was my logic, and I'm not young.
Yeah, so I'm not really worried about anything happening too much because they're healthy. But still choose Plan B because ultimately, if you're married, you can't roll the dice on your wife's health.
What happens when you're? What happens when you're? What happens when you're 32 and you don't have kids?
You get kids. You have kids.
Not everybody, but it happens. Yeah. That's a good point, right? Like,
you get pregnant.
if it was just you, you had to worry about. You might roll the dice, but you roll the dice and you end up with a pregnancy or something like that. I mean, those things are not cheap, right? Right? That makes sense. So my C group, or my group 3, y'all were split between C and D. What was your defining criteria picking between those two?
Hey, I'm the one B.
You are the one B.
I said B because I worked in a pharmacy before, and with me being however old I am and being borderline, high blood pressure. I mean, if the HSA is gonna pay for my little lisinopril that I have to get every now and again, then that's fine. And then my kids, they're probably gonna be healthy. The occasional amoxicillin, when they get sick in the wintertime. I feel like that would be good, and we can save money for vacation with the $150.
I can roll with that. I wouldn't do it, but I can roll with it. Right? What about the rest of you? C and D. What was your defining logic picking between C and D? Because they're similar. They're just different. I mean, they're both pretty good coverage plans. They just have different characteristics. What was your rationale behind picking C or D?
I know like you said, even with your 3 kids, you didn't go through the deductible. So I chose a higher deductible with lower premiums, just banking off that.
Sound logic. I'll take the lower premium, so I think I'll be all right. I can take the money that I would have spent on the extra premium, just use it to pay my deductible if I have to. Makes perfect sense. So did you pick D? Why'd you pick D? There were 4 of you, one of you had to talk.
Even with a higher premium, I'd rather have a lower deductible just in case. 3 kids, and also being hypertensive and borderline diabetic. Things can happen. And the low copay is nice too.
Yeah, that makes sense, right? Like you're willing to pay a higher premium knowing that you're going to use it more frequently. That means there's a lot of logic to that, right? All right, my last group, my 4s. Where are the 4s?
I picked D because I'm 59, married. Me and my partner both have chronic conditions. We'll probably be going to the doctor a lot. Get that deductible taken care of. The BAM insurance.
Yep. You guys catch that? You know you're gonna be using it a lot, so you want to burn through your deductible quick and make insurance pay more. So you're willing to pay a higher premium because you know that you're going to be frequenting the doctor quite a bit. You're older and whatever, right? Makes perfect sense. Anybody that picked the other ones want to pop in on that one? So here's my question. Y'all see a pattern emerging here?
Yes.
Yeah.
It's like Sudoku. See that pattern? So as you age in life, as your life circumstances change, how does that influence the type of insurance plans that you pick? Does it?
Significantly.
Significantly, right? Our idealistic millennials are all over here rolling the dice with the consumer-driven plans, right? Because you're not really worried about being sick, and life is great. You're good to go. You get a little bit older, you start thinking about things a little bit differently. You anticipate what's coming up in your next 5-10 years. You know, you guys are picking plans that are, you know, somewhere in between here. Right? Our group 4, completely different dynamic, right? You know you're going to be using the doctor and hospital quite a bit. You're creeping up in age. Right, that changes the calculus on what you're willing to pay in a monthly premium because you know that the risk is too high, right? Because things are going to happen. You know they're going to happen because they've already happened. So that changes the way that you think about things, right? So what I want you to do, stick this right here because we're going to come back and talk about this in a minute. We're going to get to it in a minute. All right, so we're going to talk about that. Let me tell you why this is important. If you try to go buy insurance in the private market, who you get grouped with? Those are different plans. So if you went to buy insurance in the private market right now, and you log in and look, you can pick consumer-driven plan, Plan A, or Plan C with these characteristics, Plan D with these characteristics. When you go in and you pick which plan do you want to be in, who else is in that same group with you?
Other people?
Well, I know it's other people.
Well, other people who are in the same boat as you.
Yes. Okay, did y'all hear that? When you go in and pick a plan, you are enrolled in a group with people who are at the same place in life that you are, have the same characteristics that you do, right? If you go to buy insurance in the private market prior to the ACA, how do you think that influenced the premiums that were set for that group, right? So what I'm getting at here is what constitutes your group is critical. So as an ETSU employee, my group is all state employees across Tennessee. Is that a big group?
Yeah.
Yeah, that's a big group. So what do you think that means for distributing the risk across the group? It's big, right? So we get a really good premium because we have a lot of people, a lot of young people, a lot of old people, a lot of people across the board. So because of the volume and probability, we get good premiums. If you end up in a private insurance group with other people that are also sick and that also anticipate having problems, what do you think your premium is going to look like compared to mine?
Higher.
It's going to be higher by a little or a lot,
A lot.
right? Let me ask you this question. I'm trying to expedite things here so we can get to a break. If you go buy insurance in the private insurance market, do you pay the full cost of the insurance or just part of it? Prior to the ACA, you pay all of it. Do I pay all of my insurance premium working for the state of Tennessee? No. How much do I pay? 20%. The state pays 80% of my insurance premium, I pay 20%. Right, so my 20% under the premium PPO, which is what I was in before I switched, is $354 a month for my family.
That's your 20%.
That's my 20%. Right, so the full cost of that is 80% more than whatever 354 is, right? You guys are smart, you can figure it out. I'm going to show you some stuff in a minute anyway. So here's what I need you to understand. This is why buying private insurance is so ridiculous. Right, because people self-select into plans based off of how sick they are and what they think they're going to use. And that creates a lot of problems because you're trying to protect yourself against risk, but you pose a risk to the insurance company and they can't predict that on the front end. So what ends up happening is you go through this underwriting process. So if you go buy insurance in the private market, and this is prior to the ACA, it's called experience rating. So what happens is when you go buy insurance in the private insurance market, the insurance company sends you through an underwriting process and they look at your health history and your experiences and they say, what is this person going to cost me? And that's how they set your premiums, right? So if I'm in a group insurance plan through the state of Tennessee, that's a community rating scheme. Everybody pays the same. So whether you're a professor or whether you're a custodian, we all pay the same thing for insurance, right? That's called community rating. So if you go buy insurance in the private market, your premiums are not based off of your group. They're based off of your group in the sense that how much are you going to pose a risk to the group that you're in, as opposed to I'm in this great big group. So you not only have to pay the full cost of that health insurance premium, but you're also paying a premium that's based off of how sick you are and how much you think you're going to cost. So one way to think about this is if you're low risk, right? So our idealistic millennials, when you guys are young, you can get away with not paying much for health insurance because you don't pose a great risk. You can buy a consumer-driven plan, you're good to go. As your risk increases, the amount that you pay gets higher and higher and higher, whereas in a community rating scheme, it's pretty standard across the board, right? That's one way to think about it. Right, so you all understand that, whenever you go buy private insurance, they have to collect enough money from the group to pay the expenses for the group. Right, so that's what your premium is. They're trying to collect enough money so they have to pay all the claims that come from that group. So here's the issue. Adverse selection. We've already described what adverse selection is. Adverse selection is we all pick plans based off of how much we're going to use it or how sick we are. What ends up happening is because all the sick people do what? They pick same plans or different plans? So all the people who know they're going to use the doctor a lot, do you think they pick a similar plan or a different one? A similar one because they all know they're going to use the doctor a lot. So what happens is all the young healthy people get in this really good pool over here where it's cheap. All the people who are really sick and actually need health insurance get over here in this really expensive pool that is ridiculously expensive because they're all sick, right? So what do you think happens over time when insurance premiums go up because they're already so much higher over here? What happens to people who are income sensitive?
They can't pay.
They drop out because it's too expensive and they just join the ranks of the uninsured. What then happens to that group after those people drop out? Does it get better or worse?
Worse.
It gets worse, right? When it gets worse, what does the insurance company do? Raises the premiums again because they got to collect enough money to cover their expenses. What happens when they raise the premiums again? Right, it's called the insurance death spiral, the private market insurance death spiral. Right, and it all comes down to the fact that people select plans based off of what they think that they're going to need, and you get in these bad pools, and it's unaffordable. Right, and I'm just going to give you some sticker shock here. So this is actually for like employer-sponsored health insurance. So in 2018, the average cost of a health insurance plan for family coverage, so like someone like me that has, you know, children or whatever, is $20,000. Right, so I only pay about $6,000 of that. State of Tennessee pays the other 80%. Okay, if you buy insurance in the private market, how much do you pay?
All of it.
All of it. So whenever we talk about affordability of insurance in the private market, let me give you an example. So my parents live in West Virginia, and like my dad's a preacher. Surprise. He's not like one of those TV preachers that make a lot of money. He's like an old country preacher, right? Like the kind that spend their life in the trenches, you know, taking care of people and getting nothing for it. So he doesn't have access to group insurance, right? Like preachers can't get together and go buy insurance. So my parents, their entire life, had to buy insurance through the private insurance market. Okay? A couple of years ago, like they're getting older, right? Like my dad is on Medicare now, so he's in pretty good shape. But there for a little while, they were kind of in this transition period. So just to give you an idea, both of them are morbidly obese. My mom is a breast cancer survivor. She has autoimmune disease. She has type 2 diabetes. Like she's basically a train wreck. My dad is pre-diabetic and takes hypertension medicine, right? So it's neither here nor there. The point is, they pose a great risk to whoever covers them. So over the years, their insurance premiums have gone up and up and up and up and up and up and up because they're in the pool with who? Other people that look just like them, right? 3 years ago, it just got where it just wasn't affordable anymore. So they were on an 80-20 plan. Right, so at 20% co-insurance, things like that. What do you think their premium was every month? $900, $300, what? 1,000? You're not even close.
1,500?
1,500, you're closer. It's like $1,600. 1,700 maybe. Right, multiply that by 12. Somebody's got a phone. What is that? Seriously, multiply it. 1,600 times 12. $20,400. Right, for two of them, just the two of them, their insurance premiums were $20,000 a year. How much money do you think a preacher makes?
Not a lot.
So I give you an idea. Their house payment is $700. They were paying double insurance premiums than what their house payment cost. So you want to know what it's like to try and buy insurance in the private market? That's what it's like. It's ridiculous. Now, this was all prior to the ACA. Now, we're not going to talk about it today, but some things the ACA did was got rid of all that nonsense, right? So there are caps on what you can charge people based off their income. They use a community rating scheme, no more underwriting. I was able to enroll my parents in an ACA plan. I got them in at $1,100, $1,200 a month. So I saved them like $500, $600 a month by enrolling them in the ACA, which is still ridiculous, but it was better than what they were. Then my mom ended up taking out a plan through, like once my dad qualified for Medicare, my mom ended up taking out a plan through her work, which is a small group plan. Like her premium was pretty reasonable. It was like $300 and something odd a month. So It's gotten better, but it's still a problem. Like what we're running into now. My mom had an accident about a year ago. She was walking up the stairs to get in the house. The stairs are about right here, like at the top, like on the side entrance. And she was carrying a bunch of stuff and slipped and fell, landed on the car, smacked her head on the ground, had an aneurysm, brain bleed, spent 3 or 4 days in the ICU, spent another week in the hospital, spent another 3 or 4 weeks in a step-down rehab facility. Right, so it was a pretty major accident, and luckily she was able to get like workers' compensation. She was able to be out of work, and they kept her job. But she was already having trouble working anyway. I'll just say that. Now you throw this major head injury on top of it, and she wasn't herself after the accident as far as like her cognitive capacity, and she's gotten better, but she's still not quite there. It was heartbreaking because what did she have to do whenever they let her go? What did she have to do? She had to go back to work. Why did she have to go back to work? Insurance. She had to keep her insurance. Like she wasn't even making enough money in paychecks to cover it. They were having to pay in, but just to keep her insurance, she had to go back to work. And like she's pretty much, well, that's neither here nor there. She just had to ride it out so that we could get COBRA to get her to where she's eligible for Medicare. Right. So this is kind of tough stuff, right? I mean, this is when you hear people say that people have to work to have insurance, like that's a perfect example. Like my mom, even with this serious brain problem, had to go back to work. Like it's sad. Like I mean, she basically like gets up, works, goes to bed. Like that's all she does because it wipes her out physically and whatever. But anyway, it's getting there. Like she actually officially resigned resigned last week. So she's kind of done working now. But now I'm left with the task of making sure she keeps coverage until she qualifies for Medicare, because clearly one incident will, they don't have any money anyway, but like that'll really do them in. So that's my job as a son who happens to know a little bit about health insurance, and it's, even with a PhD, it's like ridiculous trying to navigate. Like it's just crazy. Anyway, all right. I think that I belabor the point here, but you get the point. So here's the issue, right? Here's what it comes down to. Health insurance premiums are going up at a much faster rate than inflation and wages. So what that means practically is that as you make more money, where does all your extra money go? Covering your health insurance premiums, right? Like that's the problem that we're running into, is that even when you think you're trying to get ahead, guess what? You end up getting your insurance premiums raised, and then the raise that you thought you had ends up being less than you thought you had because now your health insurance is higher. These are just more of the same, like kind of showing, you know, premium increases before the ACA and after the ACA, what that looked like proportional to wages. Right, so when your insurance premiums are increasing at a greater pace than wages, that's bad. That means that any extra traction that you get from increased wages is not going to go as far because it's getting spent on other things. This is a visual for out-of-pocket expenses, right? So if you look at the percentage of the population employed covered by employer plans, that deductible is over $2,000. So about half of everybody now has a deductible that's over $2,000, which may or may not sound like a lot of money, but it is. All right. So I know you guys are like champs. You're hanging in there with me. I know you're tired. I know you're tired of listening to me, so I'm going to give you a break right here. But I'm just going to stop with this, and then we'll come back and talk about Medicare and Medicaid. The issue is that leading up to the ACA, you had a downward shift in the economy, right, with the recession and things that were happening. So as more people lost their jobs and lost access to insurance coverage, what happened to the uninsurance rate? Right, it was going up. So you couple that with a a decrease in employers offering health insurance, like you kind of get this recipe for an increase in the rate of uninsurance. So there was a downward shift in the economy. There was a downward shift in the number of employers that were offering health insurance to their employees. And there's been this shift more towards public and uninsured in general. So all those issues that I'm talking about with the affordability and the way that insurance was rated in the private market and the economy, all those things were kind of the backbone or the precursor to the ACA, right? So you really have to understand those things to understand the ACA, which we'll talk about next week. So I'm going to give you all a break there, and we'll come back and talk about this second piece. We'll go a little bit faster. I get a little bit fired up about the first piece. So take 5 minutes, and I'll try and speed up.
She should have gone on maximum, so she did great. But I thought she'd be one. Or she told her, but she didn't. If she corrected, it only gave me 2 points, which I think is much. Yeah, I could have got 17. I got 48. What did you get before? 72. Did you recently? Are you not Emmy? Yes, I
It's a lot of heavy stuff, and we really just scratch the surface. And a lot of that is necessary knowledge to understand the ACA. Like, you really have to understand those things to understand the ACA, which we'll see if the ACA is still there in a year or so. All right. So, let's talk about public financing. So, everything that we talked about before was in the world of group employer insurance, employer-based insurance, private market insurance, and things like that. So let's talk about public financing, like public insurance. So we talk about public sources. We're talking about Medicare, Medicaid, and CHIP. We'll talk a little bit about reimbursement structures. I'm probably not going to talk too much about that necessarily, but we're going to hit Medicare and Medicaid pretty heavily here. So, Medicare is an entitlement program for seniors. So it's based off of age. So once you hit 65, you automatically qualify for Medicare. Now, there are optional things that you can enroll in, but you automatically qualify. Medicare is standard across the U.S., right? So it doesn't matter where you live, what your income is. Once you hit 65, you are eligible for Medicare. Now, Medicaid is an eligibility program, which means that you have to meet certain criteria to qualify. So, Medicaid programs vary by state. So, they're a federal-state partnership. So, the feds have a lot of influence, but primarily Medicaid is administered at the state level. So, states set their own policies around eligibility around Medicaid, and they're primarily responsible for administering the program. So states are able to pull down a match for Medicaid. So if a state spends money on Medicaid, they pull down a match from the federal government to help support it. So it's kind of a 2-for-1. So for every $1 they spend, they get $1 back from the feds. So let's talk about Medicare first. So Medicare is passed at 65. So it guaranteed access to those over 65 regardless of your financial circumstances. Right? Medicare and Social Security came about at the same time. And what's important to understand is that both of those programs were designed to keep seniors out of poverty. So what was happening prior to 65 was that people would work their whole life, retire, think they have money, burn through it quickly because they didn't have health insurance after they retired unless they had a pension of some sort, and then they would retire in abject poverty and live out the rest of their days with nothing. So Medicare and Social Security, the combination of those two things, were designed to help keep seniors out of poverty. Right, so Social Security means that you pay into Social Security over the course of your life, and then when you retire, that money at a certain percent is available back to you. So about 16% of the total population is covered by Medicare. So Medicare averages about $670 billion a year in spending. Right, so there's a lot of money that goes through the Medicare program. So Medicare alone accounts for 14% of the federal budget. Right, so in the upcoming weeks, when you hear talk about entitlement cuts and things like that, that's why they're talking about entitlements, because Medicare comprises a big chunk of the federal budget. So Medicare has lots of parts. So Part A, like these were the parts that were passed in 65. So Part A is hospital insurance. So whenever you're admitted to the hospital, that covers any type of hospitalization. So when you turn 65, you're automatically enrolled in Part A no matter what. You automatically get this. Part B is voluntary, which covers more your outpatient care, what you would think of as traditional doctor visits, labs, and things like that. That one is voluntary. You don't have to enroll in that one. But 95% of everyone does because the premiums are pretty cheap and it covers all of your outpatient visits and things like that. Now, more recently, they've added a Medicare Advantage plan, which is kind of a managed care version of Medicare, and they've added the prescription drug benefit. Right, so these are called supplements. Right, so I had to do this. I had to go through this with my dad. So he's in all of them. He's got Part A, Part B, Part C, and Part D. Right. So the only difference in Part C is that you pay one. You know, all of your premiums, like we'll talk about this in a minute. Like you still have premiums with Medicare, but they all get paid to the managed care company that kind of navigates all that for you. So Medicare is not free, right? Like there's still out-of-pocket expenses that come with Medicare. But you can buy gap policies to cover those if you have money and things like that. And just as a note, Medicare is administered by the Center for Medicaid and Medicaid Services at the federal level, so CMS for short. So here's what's fascinating about Medicare. And I want you all to pay attention to this because I try not to be overtly political whenever I'm giving lectures because I don't want to influence you with my own opinions versus what is fact. But you're going to hear a lot about this coming up in the midterms and post-midterms in the next presidential election because of the issue with the deficit. And the GOP budget that was proposed for 2019 makes some fundamental changes to the Medicare program that when I tell you about it, I want you to just keep that in the back of your mind. So Medicare has three sources of revenue. So 41% of all the funding from Medicare, so that's 670 some odd billion, 41% of that comes from governmental outlays in the budget process. So the federal government has to take tax dollars and set aside money to pay for that. So that's 41% of the Medicare budget. So this is what gets squabbled over a lot, right? They talk about cutting because that's kind of it's kind of discretionary to some degree. So here's the trick. Here's the key. About 40% of Medicare financing comes from payroll taxes. So there's a 2.9% tax on incomes now. So when I get a paycheck every month, there's a whole list of taxes that get taken out, and one of them says Medicare. Right, so my paycheck is taxed at 3%, right, and that money goes into the Medicare budget that's used to pay for what? It's not a trick question. People who are using Medicare now, right? So I'm paying for my dad's health insurance right now. So they're taking money out of my paycheck to pay the bills for my dad. Right now, this is the way it's set up, where when you're a working adult, you get money taken out of your check and you pay it into the pot now because you know that at some point when you turn 65, it'll be your turn, and you can say, hey, I paid in this much money, so it's cool now. Like, you're willing to pay now because you know you'll use it later. But you don't really have a choice. It comes out of your check anyway, but you know what I'm saying. We don't quabble over it. So the point being is that they're using money out of paychecks now to pay for services that are occurring now. And we pay that so that when we turn 65, that money will be there for us. So it's a perpetuating program. We've already talked about the baby boomers. Well, I'm going to say that. I don't want to get too far ahead of myself. So enrollee premiums count for the rest of it, like 10, 12, 15%. So here's the key. 85 to 90% of all funding for Medicare comes from people under 65 right now. A lot of it comes through payroll taxes. So what do we know about the baby boomers?
There's a lot of them.
There's a lot of them. What are they doing? Retiring. What do we know about population demographics in the workforce right now?
It's very leans towards the older age.
I mean, to think about it this way. So, when Medicare was being enacted, and they were pulling money out of payroll taxes, setting it up, what were all the baby boomers doing then? They were working and contributing, and there was a lot of them. Over time, even though unemployment is its lowest rate, just the general shift, right? Do you have more workers in the workforce or less than what you used to? Okay, what does that do for your financing scheme if it's based off of payroll taxes? Is that good or bad? Yeah, you're in trouble. Which is exactly what's happening. So Part A, 87% of Part A gets paid for out of this trust fund. So the trust fund is where all the premiums go that are being collected now. It goes in the Medicare trust fund. They use that to pay the bills, right? And that's primarily attached to the hospital component of it. So that's key here, because that trust fund is set to go empty in 2030. What that means is they're going to run out of money to pay for Medicare in 2030. Probably sooner, actually. So, we do the math here. What year is it right now? 2018. I'm just going to round it to, so 2018, 2030, what is that? 12 years? So in 12 years or so, we'll say 15. So I'm going to tell you how old I am. If I tell you that, you would know. So I won't quite be at Medicare age when it goes empty, but I'll be getting close. So the good news is it's a short-term problem, right? Like once the baby boomers ride off into the sunset, then a lot of the expenses that are associated with Medicare might be lessened, and things might equal back out, but it's going to be a problem until then. So, what are your options here? What do you do about this?
Increase the taxes.
Reduce the entitlement.
Reduce the entitlement. So they're going to have to do something to make this money go a little bit longer, right? So you can raise taxes, raise the payroll tax, raise general outlay taxes to help pay for this, right? How popular will that be? Not very popular. You can cut reimbursement to save money, so like pay providers less. How popular do you think that is? Not very, right? Because providers have a lot of power. You can reduce services to seniors. How popular do you think that is? Right. Those are in my mind your only options, really. You think they're gonna who votes? Not like you, like philosophically who votes.
Just Senate and then House.
Even more philosophically, old people.
Old people.
Old people vote. That's right. What do you think they're going to do if you take away their Medicare? They're going to vote you out of office, right? It's going to be interesting to see how this plays out, right? And, you know, I was reading, I'm actually worried about this. Like, not for me. I'm worried about this for my mom, for example. I'll kind of keep that example rolling. So I'm doing everything I can to piece things together to keep her covered until she turns 65. Right? What do you think is in the GOP budget as one of the ways to help fix Medicare?
Raise the age.
Raise the retirement age to 67. Right, extend it 2 years. Okay, it's one of those things where it depends on where you are in life. I get it. When they first passed Medicare, life expectancy was much lower. So the window that people used to benefit was much less. Life expectancy is greater than it used to be now. It's been the same. I get it. The problem is, do you think that I will be able, because if they raise that age, then her COBRA will run out and she'll have to buy a private plan. Do you think that I will be able to buy her a private plan at age 66 with all of her medical conditions in the private market?
No.
No. The only way I could is if the ACA is still there. If the ACA is repealed, which is what's also on the table, there's no way. Like, because she has, I can think of 5 pre-existing conditions that are automatic denial right off the bat. So they wouldn't even, so if they repeal the pre-existing condition issues in the private market, if they get rid of all that, which is what would happen if they repeal the ACA, then nobody would ever have to give her an insurance plan because she has all those pre-existing conditions. I have no idea what I'll do if that happens. I can tell you this, I'm not a fan of the GOP budget going into 2019. I'll just say that. But that's a practical example of the implications of these things, right? Now, it bothers me because, you know, my mom has worked her whole life. She's paid the payroll tax, she's paid into Medicare, and now that she's getting up to that age, they're going to push the goalposts a little bit further, and that pisses me off, right? Like, as a son and somebody who will probably have to pay for that anyway, like, that's problematic. So, anyway, keep those things in mind as you hear the discussions about, you know, what's going to happen with Medicare, you know, how they're going to cut it, how they're going to shift it. You know, they're talking about privatizing Medicare, and then using the imaginary savings from privatizing to help offset the cost, which is completely ridiculous. You know, because privatizing it and giving seniors vouchers to go buy private insurance, who does that benefit? Does that benefit income-sensitive seniors like my mom? No, it benefits seniors that have a lot of money that, you know, can go get cheaper plans in the private market. People that are in rural communities, people that are in vulnerable communities, they'll end up paying more under this new scheme than they would with regular Medicare. So I'm not a fan. All right, probably wasn't obvious. So again, key thing here, Medicare is financed heavily by payroll taxes and people under 65 right now. So that shifting the demographic, big implications. Medicaid. So Medicaid was passed in 65 in conjunction with Medicare. It's the means tested entitlement. What do I mean by means tested entitlement? It means you have to meet certain income criteria to be eligible, right? So if you don't meet those criteria, then you're not eligible. So historically, you know, Medicaid was more focused on single parents, the age blind and disabled. Over time, it's been used as a policy tool to increase insurance coverage. So about 15 to 20% of the population is enrolled in Medicaid at any given point in time. So Medicaid is about 9% of the federal budget. What's important about Medicaid, Medicaid is a very misunderstood and overlooked component of the healthcare safety net. So it covers about 1 in 5 Americans. It assists about 10 million or so seniors actually are covered by Medicaid in conjunction with Medicare. Those are called dual eligibles. Right, so these are people like my grandmother who died a couple years ago who lived with our family but was dirt poor. Like she had nothing. Like after my grandfather died, like his pension ran out. Like she just lived with our family and she was able to survive, but she was dirt poor. And when she got sick and had to go in a nursing home, we had to apply for Medicaid to cover her nursing home stay. Otherwise, there was no way that we could afford it, right? So a lot of seniors that are really poor are also covered by Medicaid. So it's not just young folks. So related to that, about half of all long-term care is financed by Medicaid. So like my grandmother, for example, her long-term care stay, which was about a year, was financed by Medicaid. Critical component of the healthcare safety net, very important program. So you can be categorically eligible for Medicaid. So if you're a family receiving temporary assistance or SSI, or if you're a pregnant woman or child, like you kind of qualify based off of these different categories, or you can be income eligible. So prior to the ACA, well, even after the ACA, states are allowed to set their income thresholds for qualifying for Medicaid. So in Massachusetts, for example, it was 400% of poverty. You could still get on Medicaid. In Arkansas, it was 50% poverty. So there's wide variation in what that would be set. The ACA set it at 138. So if you're one of those states that was below 138, you were going to have to cover more people. If you were one of those states that already covered them at a higher rate, then you were in good shape. That's what ultimately got taken to the Supreme Court, and they ruled that you can't force states to do that. So some states chose to expand Medicaid under the ACA, and some didn't. So Medicaid, I already mentioned, this is a federal-state partnership. It's administered by the state. So it's a mix of federal and state dollars. So it's kind of a 50-50 match. But Medicaid is still a significant proportion of state budgets, right? Like it's really hard to finance and fund Medicaid programs at the state level. So when times of austerity come at the state level, it's really, really hard to keep Medicaid going. And everybody wants to, everybody's trying to get Medicaid to pay for stuff, I'll just say that. People are trying to get Medicaid to invest in public health programs because they save money. People try to get Medicaid to invest in, like they're constantly being hit up for money. I guess that's the best way to put it. So the only point of this is that even though it's a state program, still about 60% of all Medicaid funding in the state still comes from federal sources. So even though it's a partnership, it's still heavily financed by the feds. Another thing about Medicaid is that enrollment is affected very significantly by changes in economic condition. So if you look at this, this is looking at Medicaid spending growth and enrollment growth over time. So what happened in 98, 99? 2000 recession, right? Yeah. So there have been a couple of these like mini recessions, but like you can see, like this might be a better one to look at, right? So as recession hits, this is a complicated figure that just says whenever recessions hit and the economy goes bad, Medicaid enrollment goes up, particularly for children, right? That's the key one. All right, if you take nothing else away, from this talk, I want you to take away this. People want to talk about cutting Medicaid all the time. I used to work at state level government, and people are always wanting to cut Medicaid. People have lots of ideas about who's on Medicaid and whether they should or shouldn't be on Medicaid. It's fine, disagree with it, but whatever. It's really important to understand that when you talk about cutting Medicaid, what you're talking about cutting. So if you look at the enrollees in Medicaid programs, you look at the expenditures, okay, kids account for about half of all Medicaid enrollment. All right? They generate 21% of Medicaid spending. Adults. These are primarily low-income women, mothers, young mothers. Adults account for 15% of all Medicaid spending. Dual eligibles, people like my grandmother, and the disabled people that have medical disability. Those two account for 65% of all Medicaid spending in states. So I want you to think about that for a minute. These are people that are in institutional facilities, people that are, schizophrenic, blind, very difficult circumstances. So when you talk about cutting Medicaid, if you're really talking about putting a dent in cutting Medicaid expenditures, that's got to come from these people. Right? So think about that. It's one of those figures I like to show people whenever I'm being a little bit facetious. Right, and the point is pretty straightforward. Like, most of the people that are generating expenditures on Medicaid are not the people that you think should be on Medicaid. Right, that's the point. All right. Drivers of Medicaid spending, acute care services, prescription drugs, enrollment growth, dual eligibles, that's pretty straightforward. I already talked about the dual eligibles, like my grandmother, for example. So about 1 in 5 Medicaid folks are dual eligible. So they rely on Medicaid to cover long-term care, premiums, and some other things like that. One thing about Medicaid that we have seen happen over the past several years is that Medicaid used to be a fee-for-service operated program, and I'll explain what that means in a minute. But over time, Medicaid has shifted towards managed care. So the state will pay managed care companies to enroll people in their plans, and they work primarily with the managed care companies. So the managed care companies are responsible for developing their networks. They operate very much like a private insurance operation within states. The idea being is this is a cost control mechanism, right? So they're trying to put Medicaid enrollees in these managed care plans so that they can control utilization and keep costs down, things like that. Most of the managed care plans, and I'm familiar with those. I worked with them a lot when I was in South Carolina. They're not bad. They're fine. They're not trying to do wrong by people. They're just a managed care company, and their job is to try and control utilization, make sure that care is delivered is not excessive, but it's necessary, things like that. So, some challenges with Medicaid, obviously the ACA non-expansion is an issue. Ensuring that Medicaid enrollees have adequate access to care. Right? What I mean by that is there are a lot of providers who won't see Medicaid patients because reimbursement is low. There are places that are disproportionately Medicaid in general, like for rural communities, for example, they have a lot more folks enrolled in Medicaid that often don't have access to the provider network that they need. Again, the shifting economies and state budgets, all those things are a challenge for Medicaid. So, one thing that I want to talk about, we're kind of getting close to the end here. So one of the things that really kind of underpins a lot of these talks about the different insurance programs and healthcare spending in general, historically, the U.S. has operated in a fee-for-service reimbursement environment. What do I mean by fee-for-service? That's a good guess, yeah. It's kind of pretty straightforward. It's exactly what it sounds like. So it used to be, and most of you all are probably young enough to where you may not have experienced this, but it used to be whenever you would go to the doctor, they would get paid for everything that they did during that visit, right? So I would go to the doctor, they would bill for the visit, they would bill for the education, they would bill for the labs. Sometimes they would break the labs up into multiple labs. They would bill for anything that they could think of that would be involved with the visit. They would break it up into separate bills. Right? So it would be 5 different bills for different components of the visit. That's fee for service. So what is the incentive if you're a provider under a fee for service system?
More fee for service.
Yeah, the more things that you can think of to do and the more that you can separate out and debundle these things, the more money that you can get. So that's the way that the system operated for the longest time, and that's a lot of people attribute the skyrocketing healthcare costs to this fee-for-service environment because there was no constraints on that, and creates incentives to do a lot of things and generate a lot of services that get paid for and so on. So what's happened over time is that there's been a shift more towards prospective payment systems, and these are a little bit different. The idea with the prospective is that you contract out with these different providers and they agree to take you on and you share the cost with them. Right, so some examples of this are things like capitated rates. This is how managed care operates. So as a provider, I agree to see people at a negotiated rate which is lower than what I would think that my cost would be. And no matter what, I want to provide that service for those people regardless of what it costs. So this can take a couple different forms, right? So it can be a per member per month. So if you're a managed care company and you enroll, you negotiate, we'll take care of 1,000 people for X amount of dollars a month. So the state pays them, take care of them, and they get that money per member per month regardless of whether or not anyone comes to see them. And they do that with the agreement that when they do come to see them, that they're just going to take care of them. So it's a per member per month capitated rate. There are things like per diem, where in hospitals, you get a certain amount per patient per day for care provided. So it's a fixed rate that's agreed upon, and you have to make it work. So if that person can get out of the hospital and you spent less money than what you made, then you get to keep the profit. If you keep them longer and they cost more than what they were supposed to, you're just out of luck, right? And these are averaged out. Well, we're not going to talk too much about it, but so there's a shift towards we're not just going to pay for everything that you do. We're going to negotiate in advance. We're going to agree on a price. This is where you're going to get paid, and you have to make it work. So what's the flip side of the incentive in a capitated environment? What's the incentive on the provider side then? In a capitated prospective payment system, what are you trying to do? Cut costs, right? Like you're trying to get people out quicker. There's more of an incentive to push things through. So we're always trying to find this balance of providing the right care at the right time that is appropriate. Like you don't want to excessively provide services, but you don't want to deny people services that could help them either. And I don't think that, a lot of insurance companies and providers, like everybody's trying to get to the same point. The issue here is that when we're talking about reimbursement, the government, by government I mean CMS, like they are a major provider of healthcare services or financer of healthcare services in the U.S. They have a vested interest in controlling healthcare costs because of the things we've already talked about, particularly as it relates to the economy and so on. So the federal government is the one who has come up with these new reimbursement structures, right? So there's this misnomer, I think, that private insurance companies are the ones leading the way, coming up with these new payment structures and whatever. That's just not true. All the things that we've seen around shifting from payment for volume to value, the shift from fee-for-service to capitated services, all that stuff came from CMS. Like CMS is the originator of those transitions. So what happens is that the federal government and CMS set the tone, and whatever they do, the private insurance market follows. Right? So I think this is the one case where the innovators are not necessarily the insurance companies, the innovators are CMS, and they're innovative, not so much because they're innovative out of necessity. Right, where they're trying to control costs and they have invested interest in controlling costs. So Medicare is the one that has shifted this scene more towards prospective payment systems. So what happened is historically, just to give you a little bit of background, when Medicare first shifted this prospective payment system, what do you think happened with hospitals and providers? Today, what we're talking about, they started shifting patients around, they started cost shifting and doing some little shady things to. They're not going to lose money, right? Hospitals are crafty. If you cut their reimbursement, they're going to figure out how to get it back one way or another, and that's exactly what happened. So in response, let me back up. When Medicare came out, what happened was people were trying to shift costs onto Medicare because they get it paid for. And then Medicare responded by these DRGs, where they with this prospective payment system with a preset amount per diagnosis for hospitalization. And that's what I've already talked about. When I talk about capitated systems, like that is the early form of the DRGs and so on. So it's too late today we're all tired to get into all that, but the point being is there's been a fundamental shift in the way that healthcare is paid for in the U.S. healthcare system. It's gone from this fee-for-service operation that incentivizes increased utilization and increased billing to more of a prospective system where they're trying to pay more for value and pay for care that is appropriate more so than just paying the bills in general. And they have other versions of this that apply to physicians and outpatient clinics, but it's all kind of the same concept. So, what happened is I pulled my insurance slides out here and moved them to the front, and now this doesn't make sense. So you're going to have to roll with it here. So thinking about insurance, who has access to insurance and so on, you know, whenever we talk about access to care, there's some things that have to be in place for that to happen. You have to have services that are available, whether it's providers. You have to have accessible, you have to have services that people can get to. It has to be culturally appropriate, affordable, and all those things. One thing I'll point out, and I think this is actually the last slide, you know, when I talk about people that don't necessarily have access to care in a way that you would think, this is a map of health professional shortage areas around primary care in the country. So these, I don't know, is that purple? Does it look like purple to you? I'm sure there's a fancier term for it, but I'm going to call it purple. Yeah, whatever. These purple boxes, these are all the counties in the U.S. They're like 3,100 counties across the U.S. These purple ones are officially designated shortage areas, which means that by definition they do not have enough primary care providers to reasonably take care of the number of people that live in that county. And if you look at this, there's a lot of indigo or purple counties, right? So there are a lot of places across the country where you have primary care shortages where you just don't have enough physicians to take care of the folks that are there. And again, a lot of these are concentrated, across the rural South, the rural Midwest, and other places. So the point being is that even if you have access to insurance, in a lot of cases you just don't have access to the full suite of resources that you might have in some other communities across the country. So, it's complex. There's job security, right? So, all right. What do y'all want to talk about? Any questions? Anything else you want to know about?
I was gonna say, I wanted to know more about when uninsured people, because hospitals can't deny people coverage, so when uninsured people have to go to the hospitals and then they can't pay it and they default on those payments, and then that raises premiums more.
Yeah. So that's actually a really good question. I don't know how we're going to handle the next week's talk on healthcare reform. I was supposed to be here again next week to talk about that, which I get really fired up about, just fair warning. But Dr. Beatty and I both actually had to be in D.C., so maybe we have to record it. But I think I've got some of that in that lecture. So he was asking about how uncompensated care affects healthcare premiums. I'm paraphrasing here. So what he's getting at, there are federal rules that say that if someone comes to your facility, like your hospital, that you have to treat them until they are medically stable before you can release them, regardless of their ability to pay. So what's happened is that over time, that has been interpreted very broadly. So effectively what that means is that they have to take care of you until you're well. So if you show up at an ER and you have the flu, the ER is not going to kick you out of the ER. They're going to take care of you just like somebody that has insurance because they do not want to be sued and found guilty of violating EMTALA, which is the Emergency Medical Treatment and Assumption Act. So that's the one that says that you have to treat people. Because what was happening historically was that hospitals, people go to hospitals that have insurance, and that hospital would dump them onto the county hospitals that are publicly funded. It's kind of the anti-dumping law. So basically what it said was if they come to you, you have to take care of them until they're stable. So practically, what that means is, interpreted broadly, if someone's sick, you can't just turn them loose until you know what's wrong with them, which means that you have to do MRIs, you have to do blood tests, you have to do lots of things, which generate a lot of costs. So in doing so, because people don't have insurance, where do people go who don't have insurance when they're sick? Emergency room. Okay, what is the absolute most expensive cost center in the U.S. healthcare system? The emergency room. So when you have people using the emergency room as their primary care, you can imagine how one clutters up the ER, and two generates a lot of unnecessary expenditures to take care of them that more often than not the hospital just has to eat because the people don't have insurance. Okay, so what happens is, this is a very difficult thing to prove empirically, but what happens is, as hospitals eat more uncompensated care patients, what do you think they do to recoup those costs? They raise their prices. Who does that affect? Insurance companies, right? So when the hospital raises their prices, which are already inflated anyway because they have to negotiate down with insurance companies, right? When they raise their prices because they have a lot of uncompensated care, what happens to your insurance premiums? They go up. Right, so you see what happens? People who don't have insurance use expensive services, and as they use those expensive services, that raises the prices that are charged by the facility, which gets passed on to you as somebody that has insurance in the form of higher premiums. So basically you're paying for it whether you want to or not. Right? It might make you mad to pay for it by having higher taxes, but you're paying for it by paying higher insurance premiums anyway. So you're paying for it one way or another. Right? Does that get at your question? Yeah. And it's really, most of that type of cost shifting occurred in the 80s and 90s. Like it's a little bit harder to get away with now. And part of it comes down to, I didn't talk about this, but okay, hospitals don't know what their costs are, right, for the most part. So they know roughly how much money they've got going out and so on. So what ends up happening is, because you have insurance coming in to negotiate prices, right, what do you think hospitals do with their costs, knowing that they have to negotiate with insurance companies to come back down to what their costs really are? That they jack them up, and that's exactly the problem, right? You get these hyperinflated costs for services, and they do it, it's called the black box, because they know that the insurance company is going to negotiate down to a more reasonable rate, and that's what they're going to pay. The problem has been, prior to the ACA, if you didn't have insurance, you legitimately wanted to pay for your services, do you think that you got charged the negotiated insurance rate, or did you get charged the artificially inflated rate? You got charged the artificially inflated rate, right? Incidentally, the ACA changed that where you can only charge non-payers the negotiated rate for insurance companies. But prior to that, you get hit with these ridiculous bids, right? Which is another justification, like, if you can go and say, well, we're not, by taking care of these folks, we're losing this much money, but it's based off of a really artificial price, and use that for justification for raising the prices for everyone else, so you can see how these things work. All right, what other questions?
When looking at the graph for healthcare spending as a percentage of GDP, it's around 1980 that we started spending significantly more than other countries. What happened in 1980? Was that the 30 years?
That's a good question. So, I don't know the answer to that. Right, so I know that was the Reagan years. And I know that like inflation was a problem, and Cold War was going on, and I think there were some shifts in Medicaid expanding, which would contribute to that. You still got Medicare coming into its own with more and more folks becoming eligible for Medicare. I'm not really sure why 1980 start taking off like that. I don't know. It's a good question. I can probably Google the answer real quick, but I don't know what's off my head. Somebody has that question? No. What else?
So I know like one of the like under the radar sort of like debates in like healthcare is like tort reform. Like, can you go over that like a little bit more?
Yeah. So tort reform kind of falls under the whole medical malpractice realm. So y'all may talk about this later on in the semester, I'm not sure. So we live in a litigious society where people like to sue each other for various reasons, and doctors get sued all the time. And when you get sued, you go to court for medical malpractice, they're going to scrutinize everything that you did when treating that patient. So knowing that you were going to be scrutinized and that your liability is on the line, you think that would alter the way that you practice medicine, right? You're much more likely to provide more comprehensive tests than maybe is necessary, but you're just covering your backside in the case that you get sued. And this happens all the time. I give you an example. I know some folks, there are some very close friends of mine where, my friend's an ER doctor, and this lady came in and she saved her life, stabilized her in the ER, sent her on to surgery, and something happened in surgery where the surgeon nicked a blood vessel, and the lady bled out and almost died, and something else happened, and I don't know. So anyway, I can't remember if she died or not, but the short of it is they got sued. Okay, and the lawsuit stemmed from the surgery. But there was a chain from entry through the hospital, and every physician that was part of that chain got named in the lawsuit. Right? Actually, I think the lady survived because, if I'm not mistaken, she brought back candy to the ER folks for saving her, while her family was suing the hospital for medical malpractice because of the surgery. But my friend was named in the lawsuit, and what do you think happens when what typically happens in a lot of cases is that hospitals don't want to risk a sympathetic jury and big payouts, so they just negotiate and pay them something. And so usually a reduced rate, but they pay it, but when you look at it, it doesn't say they're not admitting guilt or innocence, they're just settling out of court. So it looks like they're guilty. So that's what happens a lot. So tort reform is the idea that if you can get a handle on medical malpractice litigation, then you could potentially have an impact on healthcare costs. Right? So here's another one of those questions for you. What percent of U.S. healthcare spending do you think is attributed to litigation and medical malpractice for which tort reform would apply? How much?
Percentage, like less than 1.
Yeah, it's less than 1%. So even if you totally got rid of medical malpractice tort reform, you would have a 1% impact on healthcare costs, right? So when you listen to politicians talk about how to address the rising healthcare costs, you hear a lot about tort reform, medical malpractice, and things like that. I'm not saying that if you could get physicians to practice in a way that it's really difficult to establish how much variation is attributed to defensive medicine. So I concede that point, but if you just look at medical malpractice litigation alone and payouts and everything that's involved with that, it's less than 1%. So if you think that that's a viable strategy for reducing healthcare costs, I'm not saying it's a bad one, but you're probably not really going to have much of an impact even if you reform medical malpractice. Those are good questions. Yeah, 8 minutes. I'm at your disposal.
Can you just the slide on eligibility criteria for Medicaid. Can you just explain it?
So you can qualify for Medicaid a couple different ways. So if you sorry, I just want to make sure I don't miss something here. So if you're age blind or disabled, you automatically qualify for Medicaid. If you get SSI payments, which is kind of a supplemental security income, like that's a disability payment, if you get disability, a certain form of disability, you automatically qualify for Medicaid. Categorical eligibility are things like if you qualify for temporary assistance to needy families, which is kind of the like the modern version of welfare, maybe I guess would be a way to describe it, then that would make you categorically eligible for Medicaid. So you're poor enough by other criteria, materially poor enough by other criteria that you can qualify. Another categorical program for Medicaid is often called optional coverage for women and children. It's called OCWIC. So states have the option to cover pregnant women and their children for a certain period during the pregnancy and for a certain time afterwards at whatever percent poverty they set. So for example, in South Carolina, they cover pregnant women under OCWI at 185% federal poverty level. So if you were pregnant, didn't have insurance, you were under that threshold, they would cover your prenatal care, pay for your delivery, cover you for 60 days postpartum, and they cover your kid for 2 years automatically. So that's a categorical eligibility program. Now, income eligibility is technically open to, I think income eligibility, anyone who meets a certain income threshold can be eligible, whether you're pregnant or not, whether you're male or female. If you meet their income criteria, they are saying that you are materially poor enough where you automatically qualify for Medicaid. So those are the two ways that you have historically been able to qualify for Medicaid. So either you fit one of these categories that make you eligible, or your income makes you eligible. Right? So there are some men that are covered by Medicaid programs, but historically it's been primarily women and children, plus these additional age blind, disabled, seniors, and so on. That help? I kind of skimmed past that one, but thought I was running out of time, but technically I wasn't. Yeah.
When I was going through Medicaid on the internet, I saw something like green card holder, citizen. This you didn't mention anything like that.
So, I believe that. So the question is, if you are not a U.S. citizen, are you eligible for Medicaid? Yeah, so if you have a green card, and you guys apparently know more about this than I do, because that's what I've looked into a lot. If you're here on a green card, if you meet those criteria, it appears that you would be eligible for those services. Now, if you're undocumented, that will be different. So I think for undocumented workers, they have emergency Medicaid for pregnant women. So if you show up, we used to have it a lot in South Carolina. So like, pregnant women who were not here on any type of visa, green card, they were undocumented, like they would just show up at the hospital in labor. And Medicaid set up a program that's called Emergency Medicaid, where they would actually pay for the delivery and a little bit of postpartum care to get them by until they can move on. But, I wouldn't really call that coverage. Yeah, for Medicare, I think you would have to be a citizen. Those are good questions. All right. 4 minutes. I'm going to keep you all here for the whole 4 minutes just because you all ate that stuff in front of me. So y'all can blame your colleagues. It depends, right? So the health savings account, like flexible spending accounts that pay for like child care and stuff like that, that usually stops after a year. The health savings account will over from year to year. So what I'm doing is, like, I'm not maxing it out. I'm going to put in a little bit and let it build up. A couple years.
Hey guys, is it possible that we can still hear her talk? Thank you.
The cap is based off of your income, right? So like when I just got the paperwork, you take your income, paycheck, there's a maximum amount you put in there. And the reason is that there's a maximum amount of, I didn't talk about this, we'll talk about it tomorrow or next week. Like usually your insurance plans have a maximum out-of-pocket number. Right, and it's like 8,000, 9,000, 10,000. So after your deductible, your co-pays and everything, no matter what, you're only going to have to pay this much out of pocket. So usually your health savings account cap is set at what your max out of pocket is. So for mine, I think it was 7,500 is the cap for what you have in your health savings account because that's all you could ever need at one time to pay in a year. So that's what it's about. Like you can't let it build up to like $30,000. All right, you got 2 minutes. You see how many push-ups you can do in 2 minutes? Take the Army physical fitness test.
Did you go to USC? Did you go to USC?
I did. This is for my PhD program.
What program?
Health Services Policy and Management. All right. You don't have any other questions? I won't hold you the last minute and a half. All right. Thank you all for being good sports. I won't physically see you next week, but you may see me on the screen.
So if the lecture is just online next week, are we not meeting in class?
That's a Dr. Beatty question. I'm out of that. I don't know. This is the last minute meeting.
You can't see me right now.